I'm going to talk about a very difficult problem today, difficult for us as surgeons and particularly difficult for the patients. It's about massive and irreparable rotator cuff tears and how to manage these. And frequently, we're choosing the lesser of evils in regards to management. We're going to go over regular anatomy and the pathoanatomy and how that ties in to indications and decision making and what we know about outcomes for this very difficult problem, which are quite limited. So we all know the deltoid is the main power generator of the shoulder. However, the shoulder, the analogies I like to give is it's a symphony. We have to have a lot of things going on at one time just to lift that arm, not just the deltoid, the rotator cuff, also the scapula and the bony anatomy. The glenohumeral joint itself, the best analogy is a golf ball and a tee. It has some inherent stability, but the rotator cuff provides that dynamic stability. And here's some anatomy of the rotator cuff. Where the probe is, that's actually the infraspinatus, but up on top here, that's the supraspinatus tendon, which assists the deltoid in forward elevation. And this is what the footprint of the insertion looks like. And this is the most common of the rotator cuff tendons that's torn. The infraspinatus and teres minor, in our terminology, we call this the posterior rotator cuff. Infraspinatus has a very large footprint, almost dog legs in, and overlaps and blends in with the supraspinatus, and that's why they're frequently torn together. And then the teres minor here, which is a player in regards to outcome when these tendons are torn. The subscapularis tendon is involved in internal rotation and stabilization of the shoulder. Also has a very large footprint. And it's unique, and one of the unique tendons that it has direct tendinous insertion on the bone and muscle fibers. The tendinous insertion is more superior and middle and provides the biomechanical effect of internal rotation and stabilization. There are direct muscle fiber insertion on the bone that biomechanically aren't really relevant and maybe vestigial. Looking at the static stabilizers, you've got the ligaments, which act as check reins, much like mooring a boat to a dock. The labrum here is a bumper, and it provides depth to the socket for some static stability. But the main function of the rotator cuff is to compress and rotate and keep the head centered on the glenoid. And in order to do this, and we're going to go through force coupling. When we classify rotator cuff tears, like everything in orthopedics, we got multiple classifications, and the one we find the best is from Christian Gerber in Switzerland. And instead of using size, because the size of the tendons are going to be different from patient to patient, and the classification for a massive cuff tear that correlates most consistently with function, prognosis, and surgical outcome is if there's two complete tendons involved in the tear. And we break that down to two very distinct anatomic patterns, the posterior superior tear, and here's an arthroscopic picture. There's your long head of the biceps tendon, your humeral head. There's what's left over here, the supraspinatus and the infraspinatus. This is also torn horizontally like a fish mouth and retracted far to the glenoid. When you see that, these have a high failure rate and they're difficult to repair. This whole glenohumeral joint space is now open, and this should be attached over here. And that's a posterior superior rotator cuff tear. And then down the road, we'll see about the different decision-making and treatment options. And then here we have the front of the humeral head, or the anterior aspect, and where the subscapularis, the biceps, and the supraspinatus should be is all exposed. So we kind of simplify this in the anatomic patterns of posterior superior and anterior superior. So we talk about the pathomechanics, or how the rotator cuff affects the function of the shoulder, and we look at things in the transverse or axial plane. This is the front of the shoulder and this is the back. This is the subscap tendon and the infraspinatus. These contract and they keep the head here centered on the glenoid. In order to optimize the biomechanics of with the center of rotation and function of the shoulder, we need the head of the humeral head here centered on the glenoid. And the rotator cuff tendons do this synergistically in front and back, and then we want the subscap and infraspinatus in what's called the frontal plane, where you'd be looking at somebody directly in front. The deltoid pulls this humeral head and it wants to go up this way like a shearing force and leave the glenoid, but it's a rotator cuff that acts as its evil twin and keeps it pulled down and keeps that ball centered on the glenoid and allows you to lift up your arm. So what happens when we lose our rotator cuff is that we get proximal humerus migration up. We start to wear eccentrically on the glenoid, and you can lead to chondromalacia, glenoid pain, and then we start rubbing on what's called the coracoacromial arch, the acromion here. This is where your bursa typically lives. That gets squeezed up against the coracoacromial ligament, and usually it's the supraspinatus, the long head of the biceps, and the subscap that's affected here. And we all hear of impingement syndrome and subacromial spurs. Well, we really think that's a secondary problem to altered biomechanics. And bone's dumb. Bone just responds to stress. You start rubbing the humeral head and rotator cuff against the top of the bone here, it starts developing more bone, and that's where your bone spur comes in down the ligament. And it's just a self-perpetuating cycle that leads to pain and inflammation. So on physical exam, we're going to look for atrophy with these chronic and massive rotator cuff tendons. Here's the outline of the scapula. This is the medial border. This is the scapular spine. And it looks like there's divots here, and that's the muscular atrophy here of the infraspinatus and here of the supraspinatus. And the patients will frequently present. They can't lift their arm up all the way, and they can't externally rotate. And you can see her right arm is limited in active external rotation compared to her left. Some of the provocative tests we do, this is called for the subscapularis, particularly the upper border, which is your most important. This is called a belly press test. The patient puts her hand flat on the belly, internally rotates the arm, and they're able to bring the elbow into the coronal plane. And to the right, they can't lift this elbow to touch my hand. And when we see that on provocative exam, we worry about a full thickness upper border subscap tear. The lift-off test is another common subscapularis test. We'll have the patient basically push off from their buttock or sacral area towards the examiner, or we'll hold it, and they can't keep it or lift off their backside. And it's demonstrated here. The patient cannot keep his arm off his sacral or buttock area. And that's indicative of a possible full-thickness subscapularis tear. The external rotation lag sign, the shoulder's in an adducted position. We externally rotate the arm, ask the patient to hold their wrist there, and when they can't, it just falls in towards the midline of their body. And that's indicative of a torn infraspinatus. They lack that external rotation function. The other external rotator in the posterior cuff is the teres minor. And when you can develop something called a hornblower sign, where you abduct the arm away from the body, much like a throwing position, externally rotate, and they can't keep that arm in external rotation, it falls down, much like the position you'd see somebody who's using a trumpet or a horn in a band. And that's how they came up with the hornblower sign. And it has pretty good specificity and sensitivity as far as physical exam findings go. And we do our x-ray evaluations, a normal shoulder. This is called a Grassi view or an AP, and we see the glenohumeral joint space is intact. There's no bone spurs. Got a nice wide acromial humeral interval. The normal acromial humeral interval on this type of x-ray, this specific x-ray, is 7 to 14 millimeters. When you get a massive rotator cuff tear and you lose that biomechanical advantage to keep the head centered on the glenoid, the head migrates up. And when you get to under 7 millimeters of this acromial, that's the acromion right there, the humerus, when that acromial humeral interval is less than 7 millimeters, you can almost guarantee you're going to have a failed rotator cuff repair and most likely have a lot of significant fatty degenerative changes to the rotator cuff musculature. And you can have this without much glenohumeral arthritis. This is a pretty clean joint, but they've got obviously have a chronic retracted rotator cuff tear. So when you get the MRIs, the point of this is to help in our decision making and predictability of whether or not surgery will benefit the patient. So we're going to look at the muscle changes associated with rotator cuff tears as a predictor of anatomic and functional outcomes. We know that size matters in rotator cuff tears. The smaller rotator cuff tears, the better and more predictable the outcomes are. The large, massive rotator cuff tears have a large failure rate, all the way up to 95%. And timing is very important, particularly with a traumatic rotator cuff tear, which most of us are, in this setting we're probably going to deal with. Traumatic rotator cuff tears are not the same animal as a degenerative rotator cuff tear. They're two different pathologic processes. And we also know, based on outcome studies, that early surgical intervention for a traumatic rotator cuff tear are going to lead to better functional outcomes and patient satisfaction as opposed to delay. Because we know with delayed surgery, we're going to also have a higher re-tear rate. So why do size and timing matter when it seems to be okay with fracture healing? But shouldn't the larger chronic rotator cuff tears heal as well as, say, a non-union or a complex fracture? No, not necessarily. Because what we see is muscle atrophy and fat infiltration into the rotator cuff muscle bellies. And these changes are proportional to the size of the tear and how old it is. And they're irreversible. Even if you're able to fix the rotator cuff, these fatty changes are permanent. And the analogy I like to give is the rotator cuff, you want the fillet. You don't want a lot of fat marbling in it. But if you get the ribeye, where you get a lot of marbling in it, then you're in trouble in regards to predictability of outcome and successful repair. So, I'm sorry? Oh, okay. So in France, Dr. Gaultier was a radiologist, developed the Gaultier classification for MRIs. Originally it was based on CT scans, but now we use the T1 sagittal. I'm very uptight about my MRIs, and this is one of the reasons why. Frequently the MRIs don't go medial enough into the supraspinatus fossa to really look for these fatty degenerative changes. You have to get past, there's the coracoid and the spine. You got to get past in there to really look at the health of the muscle bellies. And if you have a new or an acute rotator cuff tear that's retracted, it may look like atrophy, but that's just the accordion effect of the muscle in the muscle tendon unit. You got to get in there medial enough to really analyze the health of the muscle belly. Here, this guy's got the fillets. He doesn't have any fat atrophy here. So that'd be a grade 0. This is a grade 1. That's probably debatable. It could even be more of a grade 2. And here you see the muscle, and the white stuff is the fat. And this is subcutaneous fat right underneath the skin. Nice, healthy subscapularis here. Supraspinatus has a combination of muscle and fat. Should be about 25 to 25%. Grade 2, actually, I think probably should flip these pictures around. This looks a little healthier. But you get about up to 50% at a grade 2, then grade 3, and then on to grade 4. You're starting to look at obliteration of the muscle belly itself with fat infiltration. And when you get to grade 3 and grade 4, it significantly affects our ability to fix these tears successfully. So again, increased fatty degeneration has a higher re-tear rate beyond a grade 1, worse functional outcome, lower constant scores, and greater weakness in external rotation. A constant score is analogous. We have several shoulder outcome tools. I use what's called a Penn shoulder score. But these are validated patient outcome tools based on pain, function, and satisfaction. And the nice thing about this is it's reproduced in multiple studies from different authors. So this is a pretty valid predictor in regards to making surgical decisions. So why does this happen? Well, the chronic tears, you get tendon retraction, the fat invades the muscles, and then we change what's called the pennation angle, in which leads to tendon stiffness, decreased excursion of the tendon. And tendons are just pulleys. The muscle contracts, it shortens, and like a rope, it just pulls, and that's how you rotate or elevate the arm. And the other problem when you have stiffness is tendons have a resting tension when you repair them. Rotator cuff tendons do not heal well under tension. And that can lead to anatomic failure. So to better understand the pennation angle, I included this diagram. This is the vector direction of the actual tendon, and the pennation is the angulation of the different muscle fibers. So when this angle increases, you're not going to, and it shortens, it's going to decrease the excursion of that tendon. And you get a suboptimal contraction, you don't have as good a function, you don't have as good of a result. The other problem with these massive rotator cuff tears with retraction is they can kink the suprascapular nerve at 2 points, the suprascapular notch and the spinal glenoid notch. And there are EMG studies to prove this, and even getting a partial repair, which we'll talk about later, some of the pain relief from the partial repair may be from alleviating the tension or kinking of the suprascapular nerve. So what do we do at non-operative treatment? And I think this is reserved for patients without significant pain. And I think this is very relevant stuff to the work comp population, because I think people are going to be working later in life and we're going to start dealing with these problems more often. It's not just going to be the 45-year-old construction worker that falls. And you know, what's going to be available to them in regards to non-operative treatment, because not everybody wants surgery. So if you have an older patient, maybe in their late 50s, 60s, they don't want surgery, and maybe they can get a job that's sedentary or desk work, this may be a good option for them. So you want somebody who has lower functional demands. The goal for non-operative treatment with a massive irreparable cuff tear is to strengthen the anterior deltoid and the scapular muscles. The scapular muscles are very important with forward elevation. After 30 degrees of elevation, for every 2 degrees of rotation in the shoulder joint, you're going to get 1 degree of rotation of the scapula off the chest wall. That's why I always use the analogy, this is a symphony. Everything's got to work together. And so what we also want to teach them is adaptation techniques to avoid excessive stresses on the shoulder girdle. And this was what happens, I'm sorry, but with non-operative treatment, you maintain satisfactory shoulder function over 4 years, but you do run the risk of repairable tear to irreparable tear in this subset of patients that don't have significant pain but have an irreparable rotator cuff. They can have a good outcome in the short and medium terms, probably really depending on their lifestyle, their job demands, and whether it's their dominant arm or not. But we do know they can do well for about a 4-year period. So despite the minimum in the non-painful population, over the 4 years they may not have symptoms, but they do develop radiographic changes of degenerative joint disease, leading to rotator cuff arthropathy. And here was the original same patient in March 6, 1997. They have a nice wide open acromial-humeral interval, a little bit of DJD, but no real bone spurring or what we call goat's beard deformity. 4 years later, you're getting the degenerative changes consistent with osteoarthritis of the shoulder. Now you've lost your acromial-humeral interval where the rotator cuff is supposed to be. Same patient, or I'm sorry, different patient. Early on, you've got some fat atrophy, but probably a repairable cuff in regards to the supraspinatus here. A few years later, you've lost that fillet or maybe a strip steak and you've gone down to the ribeye. And then now we're most likely not going to be able to fix that cuff. So a very eloquent study and plan for these patients in regards to rehab was done over in England by Copeland and Levy, and they published this in 2008 in the Journal of Shoulder and Elbow Society. And it's about a minimum 12-week rehab, and it's for low demand or even elderly patients. And I use this a lot in my elderly patients that have massive cuff tears but no pain, and they sure as heck don't want surgery. And they found with their the constant score that can have a clinically significant improvement for their overall well-being. Their forward elevation can improve, and it's about a minimum 12-week rehab with 2 phases, which we'll go through. And you could see in this patient after her 12-week rehab, she had pseudoparalysis, which means you can't actively lift the arm up to shoulder level. And then after 12 weeks of focused anterior deltoid scapular rehab, she can get full forward elevation. And the way you go about doing this is for phase 1, first 6 weeks, we're working on range of motion. Here the doctor is assessing the functional arc of motion. And when you lay down, you minimize the effects of gravity and stress for the deltoid and the cuff on the shoulder. And she can move her arm actively from his right hand to his left hand, but she can't really do it from here to here. So the first 6 weeks, she's using her other arm for assisted range of motion in the supine position. After 6 weeks, you're going to start adding weights, such as a can of beans or even a 2-pound hand weight. And you're really strengthening that deltoid. They don't have a functional cuff. And as this gets stronger and better, they go from a supine position to a more inclined position. And they generously put together a very detailed, patient-friendly brochure, which I hand out to my patients in this program. And it's right on Google. You can just put in reading shoulder unit, but we just print them off and hand it out to the patients. They did a really nice job with this, and it's a very patient-friendly program. So what do we do if the non-operative treatment fails or they have pain and you need some type of surgical intervention. Well, we have several, there are variations on the same theme. We have limited Gold's debridement, where we're not going to be able to fix the cuff. We can decompress the area, do a bursectomy, possible limited acromioplasty, biceps tenotomy, tenodesis, and even a partial repair. And then we get to the extreme salvage procedures of tendon transfers, such as latissimus dorsi transfer, pec major transfer, and then even the reverse total shoulder. So in the limited goals debridement, and I use the term limited goals because you have to set the expectations. This is a Band-Aid procedure. Typically it'll last 1 to 4 years. It can have good early results. But anyway, the limited goal here is pain relief with the bursectomy. And there's an interesting study done out of New York with patients that had bilateral rotator cuff tears, where one shoulder was symptomatic and the other one wasn't. And in the symptomatic shoulder, you had the COX-2 enzyme and substance P, and those are neuropeptides that your anti-inflammatories try to knock out. That's the enzyme, that's their mechanism of action. And those enzymes weren't there in the asymptomatic rotator cuff tears. So a lot of times just going in there arthroscopically, cleaning out that bursa that has those painful enzymes that kick off the sensory fibers can really provide them a lot of pain relief. The problem has been in these studies is, like I said, it's a Band-Aid procedure, and it's good for patients that have preserved function or lower demands. It's not necessarily going to be that good for their strength. Here's a patient of mine that came in with a massive cuff tear. The supraspinatus and infraspinatus should be here. There's the biceps tendon. You can see some fraying as it's leaving the joint, entering the groove. And then when you pull the tendon out of the joint, that biceps tendon's pretty beat up. Tendinous structures in their virgin state should be very smooth, kind of like a baby's butt, but this is all torn and ratty. And so sometimes we'll advocate just doing an arthroscopic biceps tenotomy. And this has been backed up. This was a really nice design out of France where they looked at the outcomes of the patients with just doing an arthroscopic tenotomy or a tenodesis. And they found that the pain, activity level, mobility, and in their case, the strength did not improve, but pain, activity, and motion did improve. They did have improvement in anterior elevation, which I don't know if that could be from pain relief, because the pain can inhibit function, or could be part of an anterior deltoid rehab. The interesting thing is biomechanically, we don't think the long head of the biceps really provides any static stability to the shoulder. And they had no evidence of proximal humeral head migration in the immediate follow-up after the long head of the biceps was tenotomized or tenodesed. But why does the biceps cause pain? Well, in 2005, they did some anatomists in Greece were able to map out the sensory pain fibers right here in the long head of the biceps tendon. So pain fibers exist there, and cutting the tendon or moving it to a different location, such as underneath the pec, can give patients significant pain relief. So when we go for a partial repair, we talked about earlier, sometimes we can just restore that force couple or that balance with the rotator cuff tendons in the front and in the back. You can have a good functioning shoulder with a retracted supraspinatus tear, but you need the subscap and you need the infraspinatus to keep that ball centered on the glenoid and keep the biomechanics of the shoulder so you can lift up your arm. And here's a case example of mine. I've got a large superior rotator cuff tear coming down anteriorly into the subscap, put the anchor suture, and we tied that down. So now it's just a partial repair, but the supraspinatus is still open here. Okay, so just did a partial repair. And the other benefit, again, is we can possibly unkink or take the traction off the suprascapular nerve. And when Dr. Duralde looked at this, half his patients had an excellent result with the partial repair. Almost 75% had a good to excellent result. They made improvements in their everyday activities or activities of daily living. So now we get into tendon transfers, which we usually reserve as a salvage procedure for failed non-op or attempted rotator cuff repair. And I thought this Homer Simpson thing fit this perfect. This is a very challenging issue, and really for a decent outcome, it won't be perfect, but for a decent outcome, patient selection and indications are critical. So we look at the tendon transfer, the value of the donor tissue, meaning the tendon that we're cutting and moving to the area where the rotator cuff was torn, is very important. We determine it by the length of the muscle tendon unit, the line of action, meaning what direction is it pulling, because you want to mimic that native tendon as much as possible, and the amplitude or strength of the generated force. Here we go back. We're looking at a posterior superior rotator cuff tear, meaning the supraspinatus and the infraspinatus are involved. You want to do a latissimus dorsi transfer in the right patient. They need to be younger, and that's a very subjective. There's not a specific age requirement. A non-obese, a bigger arm, bigger lever arm, more stress on the repair. You're not going to have as good a result. And they need to have active forward elevation to the shoulder level and minimal glenohumeral arthritis. Here you can see they still have some type of coupling of what's left of their anterior and posterior cuff. Their acromial-humeral interval's intact. This gentleman's able to get up a little higher than shoulder level, likely a better candidate. And sometimes we can bring the teres major. It biomechanically is better than the lat, but isolated transfer is very difficult to perform because it has poor excursional mobility in small tendon area. So even though it's got good strength, it just doesn't line up well, and there's not much tendon. So it's much like Chris Farley here, big guy in a little coat, big muscle, little tendon. But you can move them both at the same time. So, and frequently there's anatomic variation. The teres major and latissimus dorsi tendons blend together at its insertion port on the humerus. We cut that and then bring it up. So you may be able to move both tendons together. I've done it. It's very technically challenging. So just in regards to technique, how we go about doing it, we dissect along the backside of the shoulder, isolate the tendon, free it up, and bring it out, and then tunnel it underneath the deltoid posteriorly, and we attach it into the torn rotator cuff here medially, out to the bone, laterally, and into the subscapularis tendon in front. And this is what it looks like in the real world. There's the torn rotator cuff tendon medially, or closer to the midline of the body, and the subscap tendon. Here's the transfer tendon here, and there's the subscap where you sew it in there, and the torn and retracted rotator cuff there. In regards to outcomes, Dr. Gerber out of Switzerland, one of the godfathers of modern shoulder surgery, is really the one that pioneered this technique. In his case series, he found that it improved pain and function if they had an intact subscapularis rotator cuff tendon and a negative lift-off test. They did still, however, progress to osteoarthritic changes, but were not necessarily symptomatic. Dr. Warner out of Harvard published his results. He didn't do as well. He had a 20 to 30% late rupture rate of the transferred tendon. And that led us to augmentation of the tendon. Now everyone pretty much uses either an autologous, meaning from the same patient, tensor fascia lata out of the thigh, and most of us are using some type of allograft or xenograft. The allograft is, people frequently hear of what's called graft jacket, and that's a cadaver skin from a human. The xenograft that's being used commonly is called Conexa, which are genetically engineered pigs, where everything's very consistent, and it's a very strong. This is Conexa, or the pig skin graft. Not very cellular, so the body doesn't have much of an immune reaction to it. But these can augment the strength of the repair to cut down on this late re-rupture rate. The other downside, a higher incidence or complication in regards to nerve injury than we're used to in shoulder surgery, up to 5%. Most of our complications are under 1%. So Dr. Iannotti, who I did my fellowship with, published their results with Dr. Williams out of Philadelphia, and they came up with the factors that allowed satisfactory outcomes. If the patients had a preactive active forward elevation to shoulder level, active external rotation to 20 degrees, and along with synchronous in-phase contraction of the transferred tendon, and meaning that the muscle was firing with active elevation or external rotation, they tend to have better outcomes. They try to train the latissimus to excellently rotate during elevation, and that's the challenge in physical therapy, and we use that also, some biofeedback, electronic stimulation devices. The other benefit they think is the tendon provides a tenodesis effect, and the strength is not greatly improved, just the function. So if they have a high functioning demand in regards to overhead, say they're a pipe fitter, they may improve their function, but they may not necessarily be strong enough to go back to work. So there's the hitch. When we look at the front of the shoulder, if you have a torn, retracted, irreparable supraspinatus and subscapularis tendon. Again, here's the long head of the biceps, frequently torn with rotator cuffs or vice versa. If you have a Popeye deformity that we should kind of blaze through quickly, if this long head of the bicep spontaneously ruptures, you got about a 25% chance that that cuff's going to be torn too. So if that's not fixable and it leads to instability of the shoulder, we do have an option called a pec major tendon transfer. Here in the MRI, you can see a lot of fatty infiltration and degeneration of the subscap. This humeral head is migrating out the front, leading to anterior instability. This poor gentleman has a positive belly press test. He cannot belly press on his right, but can on his left. So if they have instability and pain, you may want to consider a pec tendon transfer. And there's two ways to do this. On the young muscular patients, you can split the pec muscle, and you want to bury it, bring it underneath the conjoint tendon, which is the short head of the biceps, and there's two tendons, the short head of the biceps and the brachialis coming down from the tip of the coracoid, and that replicates the excursion or pull of the subscap tendon. That's why I want to bring it underneath this tendon structure, and this is what it looks like in vivo. So there's your transferred pec tendon, your coracoid process, which is that tip, that bony tip in the front of the shoulder, and your conjoint tendon. If you have an older patient, just not as strong or in somewhat general atrophy, you may take the whole pec unit and transfer it up to the lesser tuberosity where the subscapularis may be. So we have very limited data. This is not really scientific, more expert opinion and small case series, but it can provide pain relief, function, and stability, and mostly for isolated subscap tears. So the end game with all of this is rotator cuff arthropathy, and you think of this more in 70, 80-year-old people, not work comp patients, but I'm seeing this in younger patients who did not have their rotator cuff repaired. They're still working, and they get injured at work. So eventually you get this migration of the humerus up, this acetabulization, or you develop a concavity in the acromion because they're rubbing, and then you lose the normal anatomy of the greater tuberosity, and that's called femoralization. And this gentleman has got pseudoparalysis. He cannot actively lift up to shoulder level. He's got obvious significant fatty degenerative changes of his superior and posterior rotator cuff. Okay, that alters the mechanics of the joint. With the rotator cuff here, again, keeps the head centered on the glenoid. Here, it's up, torn rotator cuff. You're wearing essentially, you're developing arthritis on the superior half of your glenoid. Sometimes, too, you get escape or where it dislocates out the front because you lose your static restraint here of the coracoacromial ligament. Even with a massive cuff tear, this ligament is critical for the function of the shoulder. It provides a fulcrum and allows people to lift up their arm. And you can see this gentleman, when he goes to lift up, his whole humeral head dislocates out of his shoulder. Now, a anatomic or conventional shoulder replacement, rotator cuff repair, even with an augmentated device, or a tendon transfer is not going to work. They either live with this, or the only possible surgical intervention would be a reverse total shoulder, which is a joint replacement. All a reverse total shoulder does is reverse the ball in the socket and allows the tendon to compress the socket against the ball and change your center of rotation, allow you to lift up your arm without a functional rotator cuff. And it keeps it stable because it actually has some depth to it. That cup there provides some what's called wall height, and you know, like a golf ball on a tee, if your tee is a little bigger around the sides, you're going to have more stability. So we found the advantage of this, the patients have good to excellent outcomes compared to their preoperative status when it gets this severe, significant improvement in pain relief, dramatic improvement in forward elevation and abduction. And this is a total improvement of 90 to 110 degrees, not 90 to 110. People will make a jump of 90 degrees in forward elevation, 100 degrees of abduction, and if their teres minor, that tendon on the backside of the shoulder is intact, they can gain active external rotation. And if you think about what you need external rotation, you want to go do your hair, you got to have the elevation, but you've also got to be able to externally rotate to get to the back of the head, which is really important for women. I can just get a short haircut and not worry about it. So we look at outcomes, and we know that the rotator cuff arthropathy patients do better in regards to function and scores compared to revision surgery, such as if they had a massive rotator cuff that was attempted, a failed repair, if they've had a proximal humerus fracture, they fell, broke their arm, and now their tuberosity and cuff isn't working, their outcomes are not as good as the massive rotator cuff tear that was not fixable. Disadvantages, we have a really wide range of complications, from 11 to 33%, which is really borderline unacceptable. And that may require reoperation. And once you go to revision surgery, it's really hard to get a satisfactory result. And part of it is this implant went to market much farther ahead of our experience level. And we've learned most of our do's and don'ts for our European colleagues, who I don't think have the same litigation issues we have. I may be wrong on that. But there is an unknown level of activity in regards to long-term survivability. So how can these patients go back to work? I've seen somebody with a good reverse total shoulder outcome. They're happy, start doing some yard work, a few weeks of pulling the cord on the lawnmower, everything, it turns into a disaster. So you want to minimize the heavy lifting, strenuous activity, and stress across the joint to avoid the early wear, loosening, and revision surgery. So they may have to have permanent restrictions in regards to work, such as sedentary duty. The one case example I have, I had a 50-something-year-old gentleman with rheumatoid arthritis, a cop on the south side of Chicago, and he underwent a rotator cuff repair. The surgeon did an excellent job. I went in for the revision, and the rotator cuff was not repairable. The tendon was so poor, it just sawed through the suture. We couldn't fix it. So we worked on the Anterior Deltoid Rehab Center into pain management, and he was miserable. His x-rays were starting to get worse, and he ended up with a reverse total shoulder. He's no longer out on the street. Now he's got a desk job at the office or at the headquarters. Other downside here for disadvantage, we have seen a functional deterioration over a 6-year period. Initially they do well, their function seems to decline. The only caveat to that is those were patients that were older as they get into their mid-70s and early 80s, and we don't know if the functional decline is implant related or just from deconditioning that's age related. Another outcome study, 91% at 10 years had a good outcome for the reverse total shoulder, and this was for massive irreparable rotator cuff tears. You have decreased predictability and a higher complication rate if there's any revision component, such as they've had a attempted rotator cuff repair where they had to detach the deltoid to do the repair. If they have had any type of fracture surgery, your longevity and outcome is not going to be as good as a primary or index procedure for a massive irreparable rotator cuff tear. And the critical period for these implants is the first 3 years. That's where we see most of our complications in regards to infection, dislocation, and rapid loosening. And this was a disaster of a case. Fortunately, it was not mine. And you could see here the bones breaking down over time, the screw breaks, the whole implant pulled out. And the one take-home message I want to give from tendon transfers, and especially the reverse total shoulder, because this is somewhat of a flavor of the month operation, is this is a salvage operation. We don't really have any better options. The only other option is just to cut all the bone out, let it fill in with scar tissue. It's called a resection arthroplasty, and that leads to very unpredictable outcomes in regards to function and pain relief. And here's another happy patient, makes a happy surgeon. She's done really well with hers. And we're finally over with a very difficult concept or talk, and hopefully I didn't put you to sleep after lunch. Thank you.